Please, Dr. Eva.
Thank you very much. Dear Chairman, dear colleagues, let me thank to the organizers for having me here today. It's a really distinct pleasure and honor to present at this outstanding meeting. Let me walk you through the issue of use of the BiVADs and total artificial hearts in the end-stage heart failure scenario. I will refer to durable devices only. So here are my disclosures. To start off, let me first try to define the subgroup of patients who may benefit from biventricular assist device support or total artificial heart. And it's shown here, so these are the patients basically in whom LVAD is considered inefficient or contraindicated. And in the guidelines, the recommendation is in class 2A. And let me walk you through some of the parameters which may be indicative of the use of biventricular or TH. Support, low right ventricular ejection fraction, low TAPC, low RV to LV dimension, or some hemodynamic parameters such as high CVP along with the ratio of the CVP to PC wedge pressure as shown here. And also parameter which is more and more adopted in our clinical practice, which is called PAPI, pulmonary artery pressure index, which nicely demonstrates and correlates with the ventricular pulmonary coupling or uncoupling. So the PAPI less than 2 is another indication for the biventricular support or TH, and also significant tricuspid regurgitation patients at the time of the implant. In the past and at present, we have had 2 opportunities of using the durable BiVAD systems which have been amenable for this implant. It was initially the legacy device of the HVAD Medtronic, and more recently the HeartMate 3 in biventricular configuration. So let me first go back to the HVAD era, and there is a nice overview of this multicentric experience by Palak Shah, which has shown quite encouraging survival at 1 year of 61%. So, and I would like to highlight that in all these BiVAD or TH patients, we are speaking about the sickest of the sickest. So, and this is the most morbid population you can imagine, really end stage with developed multi-organ failure. So, and in this respect, these results were quite encouraging. And one important thing and take-home message for all of you is that the contemporaneous BiVAD implantation was way superior in terms of survival compared to the stage approach, while watchful waiting for the next step, adding the second pump. So the further down the road, the story continued with the HeartMate 3 assist devices. There have been some recent, some early reports by the group from Berlin, and this is an aggregate initial series published by J. Levy in the JHLT back in 2018. So, and as shown here, so the results were not super encouraging. However, to bolster some optimism to this, and I believe that Dr. Tarazi later in his presentation on his results will also show some good data on the biventricular support later in this session. So this is one of the papers from Australia by David Giffin, which shows that they could achieve with the biventricular HeartMate 3 support excellent results with less than 10% mortality, and while almost 50% of the patients have been transplanted by 18 months. And it translated to excellent survival curve as shown here. So let me briefly show one of our cases. For brevity, I will just walk you through the main part of the presentation. So we always incline now in terms of thrombogenicity and suction events to pursue with the implant to the right atrium rather than the right ventricle. We all know that the right ventricle is anatomically different than the left one. The cavity is smaller, more oval shape, and with trabeculae, and that in mind, so it always gives us the opportunity to use right atrium cannulation. I have shown already before here that you have to put some additional felt strips to facilitate the profile of the apical cuff to limit the protrusion of the inflow cannula to the right atrium. So, and shown here, so now the pump is already in place. Basically, the pump sits in the right pleural space. And after trimming, the alpha graft is sutured to the pulmonary artery. So with that in mind, this is the final configuration as it looks like. And I would strongly recommend to use extensively Gore-Tex membranes in this procedure, especially to isolate the right-sided pump from the right trunk, which may constitute a major issue at the time of the transplant. So now let me move forward to more complex issue of total artificial heart, and let me start with one remark. So with the BiVAD support, if provided the pump fails, we still have the opportunity or hope that the residual contractility of the ventricle, whether it be left or right, may be sufficient to keep the patient alive till he makes it to the hospital. So with the TAH, the bailout mode is essentially death. And with that in mind, the durability and reliability of the technology needs to be critically high. So here are the indications for use of TAH, which are in class 2B. And it comes to more complex scenarios like ventricular thrombosis, ventricular septal defects, restrictive etiology of cardiac failure, cardiac tumors, refractory arrhythmias, fulminant rejection after heart transplantation. So really even more morbid than the morbid population I have referred to you beforehand. So I will not spend that much time on the first generation device. It was Syncardia. It was a pneumatic external device with mechanical valves, and it has currently transitioned out of the market. So what might be the other opportunities we have been left for a time being? We can use two HeartMate 3 device in configuration, which is called generically HeartMate 6. Here are some early reports from Hanover and also from Vienna, and basically this is the setup, how to perform the procedure. What might be the advantages? It's a fully magnetically levitated device, so which can operate independently even in low pressure scenario of pulmonary circulation. So it's more thromboresistant than the other devices. Yet doubled peripherals represent a hindrance for the patients and for the referral. There is the absence of automated interplay between these two pumps, so it's not fully physiologic. And adhesions and need for silicone spacers to retain sufficient volume intrapericardial for future transplant is also of a concern or consideration to be mentioned. So let me share one of our cases. So this is a patient after the master procedure, after Impella implant for failed systemic right ventricle, and you can appreciate that the ventricle is the systemic right ventricle is very flat, and we have pursued as a first step with the HeartMate 3 extra-atomical implant with the alpha graft all the way through the left pleural space. Nonetheless, we have never, despite discharge of the patient, achieved good drainage, and the patient returned back with the failed non-systemic left ventricle. And that being said, we pursued with the total artificial heart conversion. So for sake of time, I will basically show the main parts of the procedure. So this is after exciting the whole heart. So you may see here the inflow cannula of the original device. So the PA was significantly dilated, bearing that in mind, so we have interposited the intermediate 24 millimeters graft to adjust the diameters of the PA and the alpha graft of the HeartMate 3. And here after the airing, you can see the final phase with two inflow cannulas nicely exposed from the left atrial side, and the final configuration for this particular patient. And bearing in mind that the patient might be eligible for the transplant in the future, we left, instead of silicone spacer, the pump in place. So that's why we have ended up essentially with the HeartMate 9. However, only two pumps were operational, of course. So now let me move to the novel devices as outlined by the chair of this session. And let me start with a pulsatile novel device. The first one who made it to the clinical arena was CARMET. We have been fortunate to be one of the first to explore the opportunities with this device. It's a biological surface device with pericardial membranes. It's pulsatile and it's auto-responsive. So it allows for a higher degree of hemocompatibility and also autoregulation. It has silent operation, dissimilar to the previous generation of total artificial heart, shows potential for full mobility of the patient, and importantly enough, from the quality perspective of life, there is only single set of peripherals compared to the HeartMate 6. So here you can see the operation of the device. So the two chambers are mounted with inlet and outlet bioprosthetic valves, and the silicone oil with two hydronic motors pushes asynchronously both membranes left and right. So, and you can see the very gentle motion of the membrane on the illustration. So it's mounted with the sensors, pressure sensors on inlets and outlets, which allows for assessment of the flow, this is reassessed each 2 milliseconds, and also it controls by the ultrasound sensors the full empty mode of the membrane to eliminate any areas of partial washout and stasis and subsequent risk of thrombosis. So it's fully pulsatile, as shown here, asynchronously, as you can see on a track lines on the right side of this slide. And also, as shown here, so we could prove that given the sensors which reflect the preload, and that being said, also the exercise needs for the patient, it has translated to very nice circadian rhythm of the cardiac output of this device. And last but not least, given these features I have mentioned before, so we could prove that unlike all other LVADs, there was no overt acquired von Willebrand syndrome, so which also plays a role. So implant technique is pretty intuitive. So of course there is a lot of pre-planning with a CT scan. The critical is distance spine to the sternum. However, the device self-positions toward the left chest, and that being said, we could over time make an evolution of less protrusion or a lower diameter or distance as shown here. So we could accept patients with the spine to sternum distance as low as 12 centimeters. So very briefly, the procedure. This is the last one. So here you can see transected heart at the level of AV valves. Now we are closing the LA appendage, which is of course mandatory. So is oversewing the coronary sinus to avoid any bleeding issue later on. So now we are fixing the proprietary apical cuffs. Which are reconstituted within the metallic lunette. And to this one, we can click by simple clicking, attach and affix the pump, and the great vessels are connected to the outflow grafts of the device. And here you can see the device and fully pulsatile mode of its operation. So with that in mind, so we have published the initial series from the CE mark, and we could show survival of 70% at 6 months. And importantly enough, so we have not encountered any strokes, thromboembolic events, or late bleeding issues, probably also attributed to this basically absence of von Willebrand acquired disease. So last but not least, let me spend the last minute on the continuous flow assist devices. I believe that the field has been recently excited by the dynamics in the US, in Houston. So there have been reported several first implants of the BiVAD core, continuous flow total artificial heart. So it's a fully magnetically levitated single impeller dual rotor device, which also bears a lot of hope for further applications for our patients, and we will be excited to see more. So with that, let me leave you, and last considerations. I believe that as long as we can use BiVAD, it should be probably a preferred choice, and the TH should be relegated for the sickest of the sickest with complex anatomies cases. We believe that we have some new technologies like CARMAT, which can contribute to the field, and obviously the next steps have to be also challenged with the BiVAD core assist device, and we are desperately waiting to learn more about the outcomes. Thank you very much.